The next disease that we are going to consider is gonorrhea. Okay, so there are a couple of different ways in which it is written down, but both are equally correct, depending on where you come from. Right, so we're going to talk about gonorrhea. Now, gonorrhea is caused by this organism, Neisseria gonorrhea. Okay, so let's take a page somewhere here and talk about Neisseria gonorrhea. Okay, Neisseria gonorrhea. So Neisseria gonorrhea is an STI that is caused by this organism called Neisseria gonorrhea. Neisseria gonorrhea. Now, Neisseria gonorrhea, this is basically a gram-negative. It is diplococci, meaning if you take a stain, you're going to find two of these cocci together. Okay, so in the field you find this cocci, it will be in pairs. Okay, so that's why it's called a diplococci. Okay. And it is an obligate aerobe. Okay, meaning it requires oxygen to thrive. Now, it doesn't live just about everywhere. It lives in a place that is warm, moist. Now, it cannot survive in a dry environment. It doesn't survive in a dry environment. So that gives us the realization that this organism would be present in the warm and moist environment in our body, which is the mucous membrane. So that's why it colonizes the mucous membranes. Now, the mucous membranes in our body give it a warm, moist environment, protects it from extreme dry conditions and extreme heat. Okay, it cannot survive in extreme heat. So that's a very good environment, the mucous membranes of our body, where it can survive. And therefore it is found in the environment in that particular area. Okay, so this organism was discovered by a German physician after whom it has been named eponymously. Okay, so this doctor was Albert Ludwig Sigismund Neisser. Okay, so that's how the name Neisseria gonorrhea has come. So it's eponymous to him. So he was the discoverer of Neisseria gonorrhea, Dr. Albert Ludwig Sigismund Neisser. Okay, so this organism is again, this is obligate aerobe, as we mentioned here. Okay, so it requires a bit of oxygen to survive. Okay, so from this we can understand that this organism infects the lower genital tract. So, the lower genital tract has got all this mucosal membrane containing areas, and the rectum, the pharynx, and the eyes. Okay, so this organism infects these areas. And it is efficiently transmitted from males to females. Okay, it is transmitted the other way around also, but it is more efficient in this transmission. Then vertical transmission also occur. Vertical transmission also occur. So what is vertical? From mother to infant. Okay, so it's transmitted from mother to infant. So when the infant is born, the infant may end up having conditions called ophthalmia, neonatorum. Okay, so this is the infection of the eye in the infant who is born to an infected mother. The infant may also be born with neonatal sepsis. Okay, so what is sepsis? The thriving of the organisms in the blood. Okay, that is called sepsis. So this is a problem. Vertical transmission also happens. If you look at the pathogenesis, let's look at the pathogenesis. This diplococci has got virulence factors. Some of the most important virulent factors are pili. Okay, so with this pili, it attaches to epithelial cells. The other virulence factor is something called an OPA protein. So OPA protein helps it to attach to the epithelial cells as well as to itself. Okay, so it helps the organism to adhere to each other and to epithelial cells. Okay, it enables it to adhere to each other and to epithelial cells. The other virulence factor is it produces beta lactamases. Okay. There are a score of other proteins also. One is pore protein. Okay, a protein called pore. So what pore protein does is it prevents the fusion of the lysosome. specifically the phagolysosome of the phagocytes. Yeah. Okay. So these are the most important virulence factors. And one thing to mention here is the pili, it undergoes changes in its antigenic structure each time that it attaches and multiplies. And therefore, we cannot make an antibody against this protein, okay, because it kind of changes every time that the organism multiplies. Okay, so that is a problem again. Okay, so we cannot immunological drugs are not very effective. Okay. So that is the pathogenesis. Now let's think about what happens. So this virulence factor, so imagine this is a cell. This is an epithelial cell. And say that is the nucleus. Let's give it this color. So let's say that is the nucleus there. This whole thing is the epithelial cell. So what happens is, and let us consider maybe this is the diplococci. Okay, it comes and using the pili, the virulence factors, it attaches and then it kind of damages the cell. And that damage brings about lots of things. Activation of the WBCs, okay, and other phagocytes, and then there is apoptosis is induced. Okay, so all in all, inflammation happens, and imagine this is the urinary tract. Imagine that is the urethra of the male, because it's quite long. And imagine this organism gets, let's use a different color. The organism gets in there, and then it attaches and damages the epithelial cell. So what happens is these cells are also, some of the organisms would be killed also. So all these things will accumulate within the urethra. We have got all these WBCs, the dead cells, apoptotic bodies, all those things are there. And these, when they come out, and then they will be discharged. Okay, so when it is discharged, it has got milky white appearance. Okay, and sometimes it is kind of off-white in color. So the people who observed it initially, they thought that it resembled semen. Okay, so if you look at the name, gonorrhea, gonor means seed, referring to the semen. Rhea meaning flow. Okay, so they're telling there is the flow of seed or the flow of semen. Okay, so that is how the name, in fact, has come about. Okay. So in both males and females, there will be discharge. Okay, there will be discharge, and this inflammation can lead to some dysuria. In females, it can cause dyspareunia, which is the pain during intercourse. So these are the presenting complaint in both males and females. Again, what is important is there would be complications if it is not treated. Okay, if it is not treated, there can be lots of complications. Okay, if not treated, there can be complications. What are the complications we are talking about? The important complications is, as we mentioned last time, this can become an ascending infection and cause salpingitis. If salpingitis is not treated in time, it can lead to pelvic inflammatory disease in the females. Okay, why in the females? Because the female reproductive tract has got openings into the abdomen, and therefore it can cause pelvic inflammatory disease. So there can be tubulo, ovarian abscesses can form. Lots of things can happen. Then HIV is facilitated. Okay, what else can happen? If it is not treated, it can lead to dissemination through the blood. Dissemination through the blood. And that can lead to systemic infections. The most serious one being septicemia. Okay, and it has also been shown to cause arthritis, which is the inflammation of the joints, dermatitis. There has also been reports of endocarditis and meningitis. So the goal of the drug therapy here is to eliminate the organism. Okay, so the goal is to eliminate organism being causative organism and to prevent the complications of not treating. Okay. And we must also remember that it is transmitted vertically. So the complications in the infant also we are trying to prevent. Okay, so that is the goal of therapy. Now, what we can observe from all these symptoms that we have talked about is there is infection in the blood, there is infection in the synovial fluid, and then in the skin, in the heart, and in the CNS. So our drug should be such a drug that penetrates into all these tissues. Okay. So that has resulted in selection of certain classes of drugs which form the regimen. Okay, let's look at what is the regimen for gonorrhea. Okay. And the drugs that are used are, let's look at the regimen, drug regimen. Okay. It is the third generation cephalosporin, which is, let's take another color here. Okay. Ceftriaxone. Okay. And ceftriaxone is 125 milligram, which is given as a single dose IM. Okay. So why single dose? Because increases compliance. Okay, so it is preferred. Okay. And ceftriaxone, we know. So let's ask a question. Why penicillins are not given? Because when we talked about the virulence factor, we said these organisms produce beta lactamases. Okay, so penicillins might not be the best idea here. Okay, but this drug has been found to be effective. What is this ceftriaxone? It is a third generation cephalosporin. Okay, so this is the regimen. Now, this is again a beta lactam antibiotic. This is a beta lactam antibiotic. So, this should be given only after doing a skin test for beta lactam hypersensitivity in the patient. Now, suppose the patient is allergic. If the patient is allergic, then allergic to what? To beta lactam antibiotics. Then the choice of drug is spectinomycin. Okay, so the first drug is ceftriaxone, and the second, which is an alternative drug, is spectinomycin. So what is spectinomycin chemically then? Yes? Good. It is an aminoglycoside. Okay, so now let's talk about the pharmacodynamics of this drug, these drugs. So ceftriaxone, it's a beta lactam antibiotic, so it is basically bactericidal. Again, bactericidal, it depends on the concentration of the drug. So if you give it in low concentrations, then it will be bacteristatic. It has been shown to be bacteristatic, but at this dose, it is a bactericidal agent. Okay, and what's the mechanism of action? It binds to penicillin binding proteins. And by binding to penicillin binding proteins, it prevents the transpeptidation reaction, and thereby, so you won't get cell walls. Okay, so if there are no cell walls, then the organism would die. What about spectinomycin? What's the mechanism of action of spectinomycin? It is a protein synthesis inhibitor. Okay, so it is, let's take another color here. Okay. This is a protein synthesis inhibitor. Okay, so what's the mechanism of action? Protein synthesis inhibitor, and this is bacteriostatic. Okay, it's an alternative drug. It binds to 30S ribosomal subunit. And thereby it inhibits what does it inhibit? Protein synthesis. It inhibits protein synthesis. Now the other point to be remembered here is that ceftriaxone, if we look at the pharmacokinetics of this drug, then it is not absorbed orally. Okay, so it has to be given parenterally. So let's write it down somewhere here. Ceftriaxone, if we look at the pharmacokinetics, absorption, it is not absorbed per oral. Therefore, it is given intramuscular. Okay, intramuscular, where is it given? It is given to the gluteus maximus. Okay, so intramuscular. What's the other thing we need to remember? Distribution. It is distributed to all tissues and it crosses BBB, the blood-brain barrier. Okay, so it has got good CNS penetration. Okay, so let's write it down. Good CNS penetration. Okay, metabolism, it is partially metabolized. Excretion, it is excreted through the urine. Okay, urinary excretion through the kidney. Okay, it is excreted through the kidney. So that's the basic pharmacokinetics and that's the pharmacodynamics. And yeah, so let's look at spectinomycin now. Spectinomycin, we did not write the dose here. So spectinomycin is given 2 to 4 grams intramuscular as a single dose as a deep IM intramuscular injection. Where is it given? Upper and outer quadrant of the buttocks. Okay, so what do we mean by upper and outer quadrant? So if I represent a buttock like this, so we divide each buttock like that, and upper and outer quadrant would be somewhere there. Okay, why? Why is it given the upper and outer quadrant? Because down below there is this sciatic nerve. So if it is given at any other location in the buttocks, it may cause sciatic nerve injury that may result in the paralysis of the legs. Okay, so to avoid that injury, it is administered deep IM in the upper and outer quadrant of the buttocks. So again, why is spectinomycin given? Because it is an alternative in beta-lactam allergic patients. Okay, so Yeah, and let the distribution, metabolism, the information, it's not very clear how it is distributed or how it is metabolized. The information is kind of lacking in the literature. But it is excreted through the kidneys. Okay, as for ceftriaxone, it is excreted through the kidneys. Okay, so these drugs basically can clear it can meet the requirement of the therapy. Okay, so it can eliminate the organism and it can thereby prevent the complications of this particular disease. Okay. Let's take the next disease. The next disease is the disease caused by Treponema pallidum, and that is syphilis. So let's take the page somewhere away from this. Oh, this looks nice. Okay, let's start here. Talking about syphilis. Okay. So syphilis is an STI that is caused by Treponema pallidum. So what is this Treponema pallidum? This is gram-negative organism. Gram-negative bacteria, and due to its shape, it is called a spirochete. Okay, it's kind of a corkscrew shape. Okay, it looks something like that. So this is called a corkscrew shape. Okay, so if you have seen a corkscrew actually, which is used to open nice wine like maybe sparkling wines, then you use this tool called a corkscrew. So the end of which looks like that. So the spirochete is likened to a corkscrew, so we call it a corkscrew shape. Okay, and it is spiral, it is having the shape because it has got endoflagella. Okay, endoflagella. Sorry, I write it down again. Okay, endoflagella. Okay, so it's got an endoflagella that gives it this corkscrew shape. So it is an obligate organism, obligate parasite. Again, because it requires a source, it requires D-glucose. So therefore, and then it requires oxygen. Therefore, it lives within the human host. Okay. So it is spread by sexual transmission. But it can also be spread, by other means like kissing, by blood transfusion, or by percutaneous injury. So syphilis it can be acquired by two means. It can be congenital or it can be acquired. Okay, acquired is how you acquire it from the environment. So if you acquire it, then you can have the disease progression is you will have early syphilis, okay, or you can have late syphilis. Okay. This early syphilis again can be again divided as primary syphilis, secondary syphilis, and latent. Okay. So what is primary syphilis? Primary syphilis is when you have it for about 14 to 28 days after getting infected, you develop something, a lesion, okay, and that lesion is called the chancre. Okay, so what is a chancre? So imagine this is the skin, a normal skin, and imagine this is the skin affected by syphilis. Okay. So what you see here in syphilis is there is an induration. Okay, there is a break in the mucosal layer, and the inner layers of the skin are exposed, and that is called a chancre. The important thing to know about chancre is that it is painless. Okay, so it's not a very painful ulcer as such. So it is kind of chancre. Okay. So after 6 to 8 weeks, there is dissemination. Okay. Dissemination basically means there is a spread. Okay. And this spread, usually hematogenous spread, it leads to symptoms. Fever, malaise, headache. Okay. Malaise is a feeling of you feel you are unwell, but you can't attribute it to any cause. Okay, you know you are unwell, but you do not know why you are unwell. So that feeling is called malaise. And headache we all know. Okay, so systemic symptoms you find when you have secondary syphilis. So latent is there is infection. Infection is present, but clinical signs are not. So if you do a diagnostic test, it will show the presence of infection, but you won't find any clinical signs. Now, the late syphilis is also called tertiary syphilis, and this is the most important complications of syphilis. Okay, it presents in three ways. One is gummatous syphilis, then there is cardiovascular syphilis, and then there is neurosyphilis. So, neurosyphilis, obviously it has got CNS presentation. Okay, it shows CNS signs. Cardiovascular, there will be, say, arrhythmias, aneurysms. Okay. Gummatous is basically a skin lesion. Okay, it's a skin lesion. Okay. But the most serious one is cardiovascular presentation and the neuro or the CNS presentation, and that is the complication of syphilis. Okay, so this is what we want to try to avoid. Okay. Then in this, again, there is an important thing I forgot to mention here. In addition, what we find here is there is rashes. Rashes are seen in the trunk, in the palm, in the soles, okay, and plaques, some plaques. It has got a specific name. It is condylomata lata. Okay, so this is again a presentation in the secondary stage. Okay, so we want to prevent these complications, and we also want to prevent congenital, meaning from mother to infant. Okay, so we want to prevent the complications there by giving a treatment. So this is the reason why we need to treat syphilis. Okay, then so we're going to look at drugs. So again, this is a regimen. The regimen for syphilis. Let's say drug regimen for syphilis. And here we are talking about uncomplicated syphilis. Okay, meaning it is not a tertiary syphilis. So the treatment is, the first one is benzathine penicillin. Okay, benzathine penicillin G, and this is given in 2.4 mega units. Okay, MU meaning mega units, given as a IM dose. It's a single dose. Okay, this is the first regimen. The second regimen is procaine penicillin again it is penicillin G, at a dose of 0.6 mega units. Again it is given IM, but it is given daily for 10 days. Okay. And the third regimen is doxycycline. Remember, we discussed it. Doxycycline, here this is 100 milligram BID, meaning twice a day, into 14 days. Okay. So these are the regimen for penicillin. So what we need to remember here is benzathine penicillin G. This is very long lasting. It lasts for about 2 to 3 weeks. Okay, it's extremely long lasting. It is the longest acting penicillin preparation. Procaine penicillin G, this is also long acting, but it has to be given on a daily basis. Okay, so it's once daily, OD. Okay, it's once daily. Doxycycline, you might have guessed, it is given for people with, in case of penicillin allergy. Okay, so whenever we talk about penicillin, we need to be very careful about allergy, hypersensitivity to penicillin. Okay? Right, so we are going to continue our discussion on penicillins. Now, penicillins, 4 to 6 hours after administration, it causes, there would be fevers, chills, headache, and myalgia. Okay. So, someone has penicillin, benzathine penicillin or procaine penicillin is administered. 4 to 6 hours after administration, the patients get fever, chills, and they complain of headache, and they have myalgia. What is myalgia? Pain in the muscles, usually skeletal muscles. Okay, so this is actually a toxicity of penicillin. Okay. This is a toxicity of penicillin. Okay. This is the reaction due to administration of penicillin, and this reaction is called Jarisch-Herxheimer reaction. Okay, so what is Jarisch-Herxheimer reaction? It is a reaction to penicillin, which presents with fever, chills, headache, and myalgia 4 to 6 hours after administration of penicillin. Okay, so Jarisch-Herxheimer reaction. So it was first described by these two people, from whose name the reaction is eponymously named after these two physicians. And the first one was Adolf Jarisch and Karl Herxheimer. Okay, so this gentleman was an Austrian dermatologist. And this gentleman was a German dermatologist. Okay, so they independently discovered, they were not working together, because this gentleman described it in 1895 and this gentleman described it in I think 1902. Yes. Okay. And so they independently described this condition. Okay. And so therefore, in honor of them, it is named Jarisch-Herxheimer reaction. Okay. So what we understand here is there is fever. Okay, so fever, chills, headache, and myalgia. So how can we manage it? We can give antipyretics. Can we give? Yes. For the symptoms, paracetamol can be given. Okay. So it can be managed. If the patient has got this, it can be managed with NSAIDs. Okay, but this is if we did not know about Jarisch-Herxheimer, this is how we would manage it. But now that we know, what we can do is we can give prophylaxis. What is the prophylaxis? It is an inflammatory reaction. So the prophylaxis would be steroid. Okay, so we know the first one is phospholipids in the cell membrane is converted by phospholipase A2, okay, into arachidonic acid. Then we have the COX and the LOX pathway. Okay, so steroids, they are anti-inflammatory because they inhibit PLA2. Okay, so that's the mechanism of action of steroids. Inhibit. What inhibits steroids? So steroids inhibit phospholipase A2 enzyme, so they can prevent inflammation. Okay, they can prevent the conversion of phospholipids to arachidonic acid. So PL is basically phospholipid and AA is arachidonic acid. COX is cyclooxygenase enzyme. LOX is lipoxygenase. Okay, so this is given about 30 to 60 milligram is administered daily OD into 3 days before administration of penicillin. Okay, so on the third day, penicillins are given intramuscular. Okay. So yeah, so that is how Jarisch-Herxheimer reaction is managed. But we have not explained what actually causes Jarisch-Herxheimer reaction. So imagine there are lots of corkscrew organisms. Okay, so this is these are all the Treponema pallidum. Okay, and you are hitting them with penicillin. You are giving penicillin intramuscular. So what happens is these cells will break down. Okay, releasing their phospholipids, their endotoxins. Okay, all these things are characteristic of, they are inflammatory mediators. They are inflammatory mediators. And these are responsible for the symptoms that is seen in Jarisch-Herxheimer reaction. Okay. But recent evidence has shown that it might be a delayed hypersensitivity reaction, meaning it might be a reaction caused by antibodies against Treponema pallidum. Okay, so this is one of the later evidences. So either way, there are two explanations. One is that it is due to the breakdown products of Treponema pallidum. That is number one reason. And the number two reason is that it is a delayed hypersensitivity reaction. So this is the explanation that is given for the Jarisch-Herxheimer reaction. Okay. All right. So the problem with penicillins again is allergy, and the most important reaction here where we have to consider Jarisch-Herxheimer reaction. Okay. So that is the most important things about the drug therapy of syphilis.